Good afternoon, everyone. Today's presentation topic is retention and relapse. This is very important phenomena in orthodontics. Once we complete the treatment, we want to retain the whatever we get the result. So this is very important topic. In our content, there is introduction, school of retention, theories of retention, causes of relapse, relapse in orthodontic surgery, relapse in cleft cases, type of retention, different retainers, retention schedule, conclusion, and references. So start with the introduction. It is proved that teeth which move through the bone using any orthodontic appliance have tendency to return to the normal position. So what is the real orthodontic challenge? It be to maintain the well-finished occlusion for the years. So this phase of the orthodontic treatment is called retention. The whole purpose is to prevent the relapse. Relapse is the loss of correction, whatever we achieve by the orthodontic treatment. And what is retention? It is a maintaining the newly moved teeth into the position long enough to aid in stabilizing their correction. So we want to retain those corrected position in the oral cavity. That all comes under retention. It is not a separate problem, but it is a part of the orthodontics. And if we want to prevent relapse after ortho treatment, we need to strictly follow the retention protocols. Stability of the orthodontic treatment is only achieved and maintained once we identify the factor which are predisposing for relapse. So we have to identify that, we have to correct that, and we have to take care of those in throughout the ortho treatment. Now there are different schools of retention. The first one is the occlusal school by Kingsley. According to Kingsley, the proper occlusion is a key factor in determining the stability of the newly moved teeth. This is very important factor, even safeguarding the stability in the new position, which is given by Kingsley. The second school is apical base school. In the middle of 1920, this school was formulated by the several authors. They suggested that the teeth must be upright in the apical bone. They should not procline, they should not retrocline, and the intercanine and intermolar width should be maintained throughout the orthodontic treatment. So that is the apical school of the retention. Then third one is the mandibular incisor school. The Graves and Tweed suggested that the post-treatment stability was increased when mandibular incisors were placed upright or slightly retroclined over the basal bone. Then muscular school. The dentition is encapsulated from outside and inside by the muscle. So there is a term development of the neutral zone in which all the teeth are lined. So all the muscle function must be in the balance in order to ensure the post-treatment stability. Now, there are different theories of the retention. The first theory is teeth that have been moved tend to return to their former position. It is already discussed. Elimination of the cause of the malocclusion will prevent the relapse. If you want to eliminate the cause, then there are more chances of the prevention of the relapse. Malocclusion should be overcorrected as a safety factor. Then proper occlusion is the potent factor in holding the teeth and their corrected position. Bone and adjacent tissue must be allowed time to reorganize around the newly positioned teeth. So that's why retainers are given. If the lower incisors are placed upright over the basal bone, so there is more likely to remain in the good alignment. The correction carried out during the period of growth, which is less likely to relapse. Further, the teeth have been moved, the lesser the risk of the relapse. Arch form, particularly in the mandibular arch, it cannot be altered by any appliance. And many treated malocclusion require permanent retaining device. Now, there are Rayleigh-Williams 6 keys to eliminate the lower or mandibular retention. And they have They have given 6 keys, which we need to follow while doing the treatment in the mandibular arch. The incisor edge of the lower incisor, it should be posed into anterior posterior line or 1 millimeter in front of this. So the incisors should be upright in the apical bone. So this position of the lower incisor, which ensures the stability of the following treatment. The second key is the lower incisor apices should be spread distally to the crown more than is generally considered appropriate. So apices of the lower incisor must be spread more than those of the central incisor. So the lower incisor apices should be spread distally and crown mesially. So it is appropriate and which is more stabilized than upright. Now third key, the apex of the lower cuspid should be positioned distal to the crown. All the 4 incisors must be in the same libiolingual plane. The lower cuspid root must not be positioned slightly buccal to the crown apex. The lower incisor should be slenderized as they needed after treatment to prevent the blood triangle. So, all the 4 incisor apices must be in the same labiolingual plane. So, retention phase following the orthodontic treatment, which is required to allow, why this is required? To allow for periodontal and gingival reorganization, to minimize the changes in the orthodontic results, to permit the neuromuscular adaptation, and to maintain the unstable tooth position. So, for this reason, the retention phase is required. Now, what are the causes of relapse? The causes of relapse which includes there is a soft tissue factor in which there is a muscle factor. Then other are the supporting tissue. There is a reorganization of periodontal fiber and reorganization of the gingival fiber. Then occlusal factor in which there is a tooth size discrepancy, axial inclination, transverse discrepancy, and sometimes third molar. Then facial growth and occlusal development. Now, orthodontic results potentially unstable due to there is a developmental changes in the dentition over time to time. Then second is the reorganization of periodontal and gingival tissue. Neuromuscular adaptation to the new occlusion. Specific orthodontic sometimes of tooth movement like severely rotated teeth correction. Aging and late growth of the mandible. Abnormal muscle behavior or oral function and development of the third molar. Sometimes relapse in the orthodontic surgical case also very important to take part in orthodontic treatment. So the stable and function in occlusion is mandatory for the success of the orthodontic surgery. Pre-surgical orthodontic treatment followed by post-surgical orthodontic phase, which is also mandatory to achieve the good occlusion and for longer retention. Sometimes the surgical relapse also we need to consider before doing the surgery. So one of the method to minimize the relapse is to slightly rotate the mandible clockwise to minimally alter the position and also have the rigid fixation. Sometimes muscles also play a significant role in relapse. So we need to take care of that while surgery. Now relapse in the cleft cases. Children with a repaired unilateral and bilateral cleft of the palate have the bony deficient maxilla in the midline and also in the alveolus. So if we treat those cases with the surgeries, there is development of the palatal scar. So due to the lack of bony structure and development of the more scar tissue, there is sometimes chances of the relapse, which is small. So in this patient, if we require there is dentoalveolar expansion, so we require the secondary bone grafting after correction of the surgery. Even good intercustation and maintenance of the occlusion also required in cleft palate and cases. Sometimes a rigid fixed retainer with the wire component extended lingual to the all teeth, which is recommended in all the cleft patients to prevent the relapse. Now, there are different retainer appliances. Retainer is an orthodontic appliance which given us after debonding or the fixed appliances to completion of the active treatment with the functional or the removable appliances. So they are the appliances which we give to the patient after finishing with the orthodontic treatment. So classification of the retainer. First is the conventional removable retainer, in which there is tooth positioners, Holly's retainer, Bates retainer, Holly's retainer with anterior bite plane, Holly's retainer with reverse bite plane. In fixed lingual retainer, there is a flexible spiral wire retainer, preform 3-3 bonded retainer, lower lingual arch as a retainer, and retainers after dentofacial orthopedics. There is a chin cup, headgear, and anterior and posterior bite plate. Now you can see the figure of the Holly appliance, which is the most commonly used retainer in the day-to-day practice, which was given by Charles Holly in 1920. It helps in closing the space visible to the canine with using the long labial bow in case of extraction cases. Even we can incorporate anterior bite plane to retain or correct the deep bite cases. Second one is the badge retainer. It is given by PR badge. Advantage of this retainer is there is no crossover wire between the canine and the premolar. So it eliminates the risk of the space opening up. So this is very best retainer to give in the extraction cases. Then chin cup retainer. This is commonly made with the wire framework that run labially over the incisor and passes between the canine and the premolar and recurved again to the lingual surface and acrylic added to the lingual surface. This is used in correction of the rotation in the lower anterior teeth and which is commonly used because there are both labial and lingual components. Then come to the Kesslin tooth positioner. It is given by H.D. Kesslin in 1945. It is made up of thermoplastic rubber material and it is clear. So it is very easy for the patient to wear. The only problem with this aligner is there is a difficulty in speech and sometimes if there is development of the risk in the TMJ. Then bonded lingual retainer. The stainless steel or blue alveolar wire is adapted lingually to follow the curvature of the lingual. This is also commonly used, but sometimes there is debonding of the retainer happen and there are chances of the relapse. Now banded canine to canine retainer, which is used in the lower anterior region. The band is predisposed to poor oral hygiene and it is unaesthetic. But we can correct the lower incisor rotation. We can maintain the lower incisor rotation correction after the orthodontic treatment with this retainer. Then comes to the band and spur retainer. It is used in case when there is single tooth is orthodontically treated for either rotation correction or labiolingual displacement. Then Essex retainer, there is a clear plastic shell that contours the teeth to aid in the maintenance of the tooth position. There is the Essex retainer. Now, what is the retention schedule? Some common principles that governs the retention schedule include minimum 6 months of day and night wear of retention appliance, which is extended up to 1 year. If we follow proper retention protocols, so this is a normal retention schedule. The patient should advise to wear retainer 24 hours, taking them out at the brushing and cleaning thoroughly. Patients should regularly report for the review of retainer and possible chances of relapse. After a few weeks, occlusion is checked for the centric relation and occlusion. Then we can discontinue the retainer. So retention plan, which is summarized by Kaplan, that is the limited or short-term retention, moderate retention, and prolonged or permanent retention. So retention, it is a part of the orthodontic diagnosis and treatment planning and perhaps the most difficult part of the active orthodontic treatment. The choice of retention appliance and retention protocol, which varies in each patient according to the malocclusion, treatment mechanics, extraction pattern, craniofacial morphology, and periodontal health. So prevention of relapse is not a less challenging than the doing orthodontic treatment. These are references. Thank you.